Hi, I'm Natalie May. I'm a final year trainee in emergency medicine in Manchester, and as part of my NHS Change Day pledge, I've put together this short talk about blood gas sampling for junior doctors and medical students. I hope you find it useful. In emergency medicine, we're really big on practicing evidence-based medicine. What this really means is that we encourage EM practitioners to think critically not just about what they're doing, but why they're doing it. And we hope that putting the best available evidence into practice means we can do the best for our patients. Blood gas analysis is a point-of-care test which can provide useful information in a variety of clinical scenarios. The big question is whether the sample should come from a vein or artery. Traditional teaching is that venous gases are inaccurate and arterial gases are superior. This is what American EM physician Joe Lex calls GobSat, good old blokes sat around a table deciding what the best thing to do is. Perhaps it would be more sensible if we had a look at the evidence. A study in 2010 looked at the agreement in values from samples taken as arterial and venous blood gases. It found good agreement for pH and bicarbonate values in samples taken from patients with exacerbations of COPD, but not between PCO2 and PO2. What this reminds us is that we need to ask why we want to take the sample. What information do we need it to show us? If we want to know whether or not the patient is acidemic, i.e. the pH is less than 7.35, or acidotic, where the pH might be normal but compensated by respiratory or metabolic mechanisms, a venous gas can give us that information. This study from 2006 showed that VBGs provided sufficient agreement with ABGs to be used in their place for patients in DKA. What's more, this paper published in 2002 showed that in suspected type 2 respiratory failure, not only was pH in a venous gas an acceptable substitute for arterial, that PCO2 could be used as a screening test to rule out hypercapnia from a venous sample alone if the measurement was less than 45 millimetres of mercury or 6 kilopascals. So what information do you get from an ABG? Well, you can get an arterial oxygen level, except that in order to do this accurately, the patient either needs to be in room air, in which case, how concerned are you really about significant hypoxia, or you need to invoke the highly complicated mystery of the alveolar gas equation. The alveolar gas equation, it's complicated, but if you're truly taking an arterial sample to assess the degree of hypoxia, it's something you need to look at. If your patient is sick enough to need accurate calculation of their oxygenation, arguably they should be looked after in a high dependency area, and if that's the case, an arterial line will allow regular sampling rather than you just stabbing them once for a blood gas. Luckily, there's a simpler way. In the majority of circumstances and in most patients, saturation monitoring will be an accurate proxy for oxygenation, and actually, oxygen carriage is more important than partial pressure. Here's a blood gas from a patient with tissue hypoxia, but high PO2, so he had a high dissolved oxygen concentration in his blood. His SATS reading told the story here. The ABG does give the answer about what's going on, but it's got nothing to do with his oxygenation, and actually the answer was available on the venous gas as well. Anyway, we don't need to get into the hemoglobinopathies at this stage. I just want you to think about whether an ABG is really necessary. And why do we need to ask this question? Well, because it hurts, as you'll see if you watch to the end of this video. So there are definitely circumstances in which VBGs can tell us what we need. DKA, sepsis and renal failure are good examples. Anything where your primary concern is acid-base balance. In a pink, well-perfused patient with good SATs which don't dip on exertion, an ABG probably won't add much. Even in your COPD patients, you can rule out hypercapnia with good reliability if the PCO2 is less than 6 on the venous gas. A less painful alternative than arterial sampling is earlobe capillary gases. These are frequently used in paediatric practice, and this study shows there is excellent agreement in PO2 levels, particularly below 8 kilopascals, so that's the hypoxic patients. This is something we've known since 1994, and yet we rarely use it in practice. In the ED, if you want to do this, you'll usually find your capillary tubes on the paediatric resus trolley. So if you absolutely have to do an ABG, for example, if your patient is hypotensive, please, please, please use local anaesthetic. It hurts significantly less, especially if you're not very good at obtaining ABGs. And it's in the BTS guidelines that local anaesthesia should be used for all arterial blood gas specimens except in emergencies or if the patient is unconscious or anaesthetised. To administer local anaesthetic prior to ABG sampling, explain the procedure to the patient and clean the skin as normal. Then infiltrate 0.1 to 0.2 ml of 1% lidocaine subcutaneously using an insulin syringe like these ones, remembering to aspirate before injecting. Inject slowly. You will see a bleb raise under the skin. Withdraw, safely dispose of your insulin needle and then massage the area. And you need to allow at least 60 seconds for the local anaesthetic to start working. Some people will tell you that giving local anaesthetic is pointless, as it means the patient gets 2 needles instead of 1 and that the local anaesthetic itself hurts. Well, let's lies that dogma. A typical 1 ml entrance syringe has a 29 or 30 gauge needle, so it's absolutely tiny compared to the 22 or 25 gauge needle on your ABG syringe. And while local stings a tiny bit, you can reduce that by infiltrating slowly or warming the local anaesthetic. In any case, patients who've had ABGs both with and without local tell us that local makes it less painful, as this paper showed. To maximise your chances of success, positioning is key. Ask the patient to extend their wrist and rest your hand on their palm, encouraging them to keep their wrist relaxed. The radial artery is very superficial, always more superficial than you think, so approach the skin with the needle really, really flat, and this will maximise your chances of hitting the vessel the first time. You can find an excellent step-by-step guide to obtaining ABGs on the OSCE Skills website. Some patients may choose not to have local anaesthetic, and that's fine, but my pledge for NHS Change Day 2014 is to at least offer local anaesthetic to all the patients I'm taking an arterial sample from if they are conscious. You can like, view or join my pledge here at the NHS Change Day website. Arterial blood gases are useful, but we should really think about why we're performing them. For more information, see the BTS guidelines for emergency oxygen use and this great blog post by Alan Grayson at the St Emlyn's blog. In summary, our take-home messages. Number 1, please think. Do you actually need an arterial gas, or will a capillary or venous sample give you the same information? Please offer your patient local anaesthetic and use an insulin syringe to administer it, injecting slowly and allowing at least 60 seconds for it to work. And think about the positioning of your patient for best results. And now the bit I've really not been looking forward to, a short video to complete my Change Day pledge, in which Alan Grayson and I find out just how painful ABGs really are in the hands of some very brave medical students. We ready?
You're ready, yeah.
Hi, I'm Natalie May, and this is part of my NHS Change Day pledge 2014. I'm about to sacrifice my wrist to have an arterial blood gas without local anaesthetic and then one with local anaesthetic to see what it's like for patients. And my pledge is that I pledge to always offer local anaesthetic to my conscious patients in whom I'm going to perform an arterial blood gas, and do venous blood gases whenever an arterial blood gas is not necessary. So, let's do it. To introduce yourself to the camera, tell us who you are.
Hi, I'm Mary. I'm an integrating student between 4th and 5th year.
Do you have any facts? Any cleaning? There was some cleaning. Stuff around. You got some claw prep, Alan?
Yeah. You've got some out, just a second ago.
What do you want? Blood?
Do you want to
Have we got a sharp spin? What are you going to do with this needle afterwards? Don't put that in the video. So flick that orange bit out of the way. That's it.
push it firmly on and then pull it off, that's it.
Do I need to expel anything from this?
No, it's fine.
It's the principle of just being stabbed in the wrist, really, that bloody hurts.
Okay, you ready?
Yeah. Let me move my fingers for you. Nice and flat. Okay. That's quite sore.
Sorry.
No, carry on. That's what I'm here for. Go for the pain.
Okay.
Yeah, I'm surviving.
The hand's not turning blue yet.
Oh, there we go.
Yeah, am I right?
Marvellous. Oh, thank you.
Hemorrhage.
Yeah. Have some tranexamic acid, please.
There you go.
Awesome. Okay, so that was quite uncomfortable. Not the most fun I've ever had after a night shift, I have to say. So we will apply some local to the other side and then provide a wonderful N=2 trial with Dr. Grayson. Okay, so that was a scratch. Stings a tiny bit, not too much. So we'll give that at least 60 seconds, hopefully near 90 seconds to work. That doesn't hurt at all now, so we'll let that local anaesthetic work. Meanwhile, Alan is going to have his first non-local blood gas.
People queuing up to do it.
That would be if it was a blood gas from the eye, Nick. Do your worst, Chris. Hello, I'm Alan Grayson. I'm a consultant emergency physician, and for some strange reason I've been conned into this for an NHS Change Day. However, I did write a blog post on why you should be a lot nicer. That's forming the basis of this Change Day article, and I'd really like it if you used local anaesthetic for your blood gases, and I'd really quite like it if you warmed your local anaesthetic because it hurts less as well. Also, you should consider really whether you do need an arterial blood gas and whether it's going to change your management, and you can view my blog post on stemlynsblog.org. Do your worst, Mr. Wheeler.
I'm Chris, I'm a medical student. I'm going to try not to hurt too much.
There is no conflict of interest because I am not assessing Chris for his final exam.
That you know of. Just going to pull that down a bit because it's in the way chest.
I'm not looking forward to this.
I'm sorry about that.
Scratch going.
Not the most pleasant experience I've ever had, but not too bad. The not digging around certainly helps.
It was, but
Yeah, of course.
thank you.
Maybe fill in a docs with it. Oh,
Yeah.
Both have a docs doctor.
Yeah, find us on Medley. Do you want to pop some
Yeah.
Lido in that
That's a new
side?
syringe, is it? I take
That's
it.
a new syringe.
Put some gloves on.
Don't need gloves.
The,
I'm bleeding out of one of my hands. A little bit.
bad news, there's no DOPS in ABGs.
Oh.
Is there not?
Believe it or not.
There was one, and then it mysteriously disappeared. Yeah. Oops, there.
Yeah.
So we're going on the other side.
Okay. Alright, sharp scratch. Aspirating a little bit. I'm going to go nice and slowly. Get 0.2 mils, I feel generous.
There we go.
Didn't even bleed. Give it a rub for you. How's that?
Thank you.
You're welcome. All about holistic care.
Do you want to grab that?
Yes, we'll be fine now.
Alright.
Hemorrhaging from my radial arteries.
Only got a little bruise, it'll be alright. So, my left wrist, helpfully infiltrated with some lignocaine. Feels alright so far, but it's just the cleaning. And it is nice and numb, I have already checked. Alright, attempt 2. Yeah. You ready? Yeah. Sorry, I'm buffing it up. Can't feel this one as easily.
cunningly given the harder side, but made that one numb so it doesn't matter quite so much.
Okay, you ready?
Yeah. I can't feel anything. I didn't. Have you gone through the skin?
Yeah.
I honestly didn't even know.
Can you feel that?
Not at all. Felt that a little bit. I think it might be a little bit fine.
Okay.
But that was a tiny twinge. Like it's nothing. It wasn't all that bad on the other side, but I can't feel anything on the side. Definitely much preferable. Yeah, I feel that. I think that might have hit my radius,
Sorry.
or possibly the radial nerve. Yeah, flatter is always the answer. Always the answer.
Ignore the textbooks and go in
Always
about
go flat.
30 to 50
Always
degrees.
flat. Flat as you like.
High or
About
low?
30 degrees.
No, flat,
Flat.
flat, flat, flat.
Oh, right, okay.
Yeah, about
Withdraw a
that.
bit,
You're
go
right.
in flat, and you will get it.
How's that?
Still can't feel anything. I don't even mind if you don't do it. I think the point's been proved. You've
Yeah.
dug around in there, and I only felt a little twinge when you got to bone, I think, or nerve. But
So it's-
even that, I don't mind. Up to you. If you want to keep trying, I'm not bothered.
I'll give one more go.
Okay.
If I don't get it then. No. Okay, can I stop?
Yeah, of course you can. That was absolutely fine. You could have carried on there for another 5 minutes. Compared to, I didn't think it was that painful on the other side, but comparing the two, I would have local anaesthetic every time, particularly for the amount of time that it throbbed for afterwards, and that just doesn't hurt at all. And now, Dr. Grayson.
He has a radial artery on his left-hand side. Right, sir.
Actually, still throbbing a bit on this side.
It's just it's unpleasant on there
Yeah.
on the side of that left
I would say the throbbing afterwards is worse than the stabbing,
Yeah.
but there's nothing on this side at all.
Still not looking forward to it.
I'm not sure I'd volunteer to have this done again without local.
I remember once being cannulated with a blue cannula by a Bulgarian medical student, and my hand blew up like a plum.
Scratch going. Can you feel that?
No, I can't feel anything at all. It's actually
It's incredible the
It's
difference.
amazing the difference.
I honestly didn't think it was that bad, but comparing the two, it's phenomenally different.
It's definitely a little bit harder to feel. That's flat enough, isn't it?
Yeah, that's fine. I think you need to come a bit more medial, mate. Yeah, it's all right, isn't it? Really. So I think this is an NHS Change Day pledge worth making. was my radial nerve.
But even that is not the same pain. It's not as
No.
bad as the pain of just
Almost out.
the digging in the wrist.
Yeah, about there. About there. It's not that deep, mate.
No.
Alright. I'm glad you're practicing on me rather than one of my patients. Well, I think it's only fair, isn't it?
So next year, NG tubes?
Yeah, and Sherry.
Catheters.
No, no thanks. So the slight problem we've got is that with local anaesthetic,
It's
they didn't
harder.
manage to do
Do you
it.
want to stick a pair of gloves on?
Is that a clean thing or should I get one out of the bucket?
Yes, thank you very much.
Sorry,
Well
sir.
done. Thank you for being our guinea pig.
Thank you. No,
I'm
thank
sure-
you so much. Your contribution was
If you
highly
need anything,
valued.
you've got my email address. It's Nick, yeah, Nick.Smith.
Yeah.
So if there's anything you need, yeah, it's medicine or anything like that, then come from me. Oh, we're just getting on already.
Bye.
Take care.
Don't mess around with me. All about preparation. It's not difficult, is it?
No.
Marvellous. Was that all right for you, sir?
Absolutely fine, thank you.
Did you feel anything at all?
No,
Well, there you go. What a nice, happy story.
brilliant. I'm much rather love local anaesthetic.
Yeah,
wouldn't you?
absolutely, every time. So, join our pledge, like our pledge, visit the NHS Change Day website, join and like it, and please, please, please give your patients local anaesthetic before they have arterial blood gases. Thank you very much. I'm going to bed.
I'm going to work.
So, how far away was it?
You weren't far away at all. Nats was just there. It's. Can you send me a copy of that?
I can, once I've edited it.
Yes.
No, can you send me a copy of it as it? I just want to show it
Blank.
to my
Yeah.
FY1s tomorrow.